Okay, good afternoon, friends. So this is the case that we did during the IJCTO 2024 at Hyderabad. We were doing it at the Care Hospital. We have with us Dr. Vishwanath with me. This was a patient who had inferior MI, was having angina for about 2 years and presented with an inferior MI and was having a RCA that was occluded and which was done locally. And at that time, the LAD was, as you see here, was found to be a chronic total occlusion and in the mid segment. And so they left the LAD for the second stage, and that's what we were planning to do now. So I have two catheters, both from the groin because the radial was not accessible because of the previous procedure. And we have a 7 French EBU in the left and a 6 French EBU in the right. And as you see, the mid segment of the LAD is occluded and it actually runs into a septal. If you see, that's where the septal runs down. And the distal LAD is actually filling from collaterals. So it's a true total occlusion, and the distal LAD is filling through collaterals. But with that short segment and a mid segment LAD with a tapered tip, I thought it's antegrade would be the right approach, and we really planned for antegrade only. And not a very difficult case, but yes, if you can get subintimal, and then there's a problem. The plan would be to have a microcatheter and a Sion wire to get the microcatheter into position, and then we will get on to the CTO wires. So I think this is the micro and the Sion wire. So the Sion, I'll take it to the proximal stump of the CTO, the micro to follow, and then we'll change wires because I'm sure the Sion would not go. So that's what we'll see what happens to the Sion. So as it comes down, you see that. So either it's heading towards the septal or that's you see the buckling. So it is buckling down. So because that's not going to go. So the micro reaches the proximal cap, you pull out the Sion, and then we change to XT type of a wire. XTA might be good because XTA you can direct it, hydrophilic polymer jacketed wire with a tapered tip, but you can direct it. So, and with a composite core tip. So that is why I chose XTA. So let us see what happens with XTA. So that is a XTA going down. And in these situations, when you have a patent vessel just before, that's the septal, well, most of your wires will have a tendency to go into the septal because the true occlusion or the true CTO segment would be sort of partly protected by the septal, and you always head into the septal. So let us see. So that is the XDA with again a small tip. The tip is, I make a tip of maybe about 2 millimeter. That's it, at about 45 degrees. So, and the microcatheter is a caravel here. And you see, we are trying to go down. Well, these actions have to be slow, so we have to have some patience in antegrade wiring. So keep checking in the other view. This is the LAO view, because so that we know where we are. Actually, the vessel in front, if you see on the LAO view, is actually the septal. And then there's a diagonal behind, and the LAD is in between. So we have the septals, the LAD, and a diagonal also overlaps in LAO view. So the XTA seems to progress. So looks hopeful. Let's see, but doesn't look exactly into the LAD. But yes, it is moving forward. And we need to cross-check in the RAO view because it could be in the septal, and there it is. You see, it has only gone into the septal, so nothing in the LAD. So I think what we need is a more penetrative wire and a wire which can be directed so that somehow we have to pick up the mouth towards the LAD rather than the one that is leading into the septum. So again, trying to redirect it. Uh, you can see my hand movements very slow. So seems to be progressing in the RAO. Again, I think it will go into the septum. So not progressing. So then change wire. So now we need a still stronger wire. And my usual strategy is at this stage to change over at least to Gaia 2. And Gaia series of wires are ones which you can direct, and they have better penetration efficiency, as you know, with that Act 1 tip. So that's a Gaia 2 coming up. Okay. So we'll try to keep the tip superiorly so that we don't get into the septal in the RAO view at least. So yes, so it has probably crossed the region of septal origin and is moving in the direction of LAD. There it is, cross-checking with contralateral injections. So you see that the wire is almost in LAD, but always you need to cross-check. Sometimes it may not be, the other view could be totally different. That's what the three-dimensional concept is. So you see that the shaft is the shaft of the wire and the tip. There it is. In the LAO view, you see it is behind the LAD. It is posterior. So that means we are not in plane. And that is the 3D concept. Then I thought I will do 3D wiring. So as you see in the RAO view, the shaft is almost overlapping the distal vessel fillet, but the tip is directed posterior. Okay. So the three-dimensional concept, how we use the slide I have overlaid. Now you see in the LAO view, the shaft is posterior or behind, but in RAO view, the shaft is overlapped. So probably the shaft of the wire is left and posterior to the true vessel. Now, similarly, the wire tip is posterior or behind, as you see here in the LAO view, and is also posterior and behind in the RAO view, right? So with that posterior and behind, you will see it as it moves. The tip is probably true posterior. So with the shaft left and posterior of the true vessel and the tip further directed true posterior, what is required? Yes, you see it is the tip is posterior. What is required is that with the shaft posterior and left and the tip true posterior, you need to move 135 degrees on the tip counterclockwise, which so that it will get directed anterior and right and then penetrate, because it has to be vertical to that artery. And how it will happen is in LAO view, you will see it going anterior, and in RAO view, you will see the tip almost end on. So now when I maneuver the wire, I will keep in mind to keep the tip towards the front in LAO, which was behind, and slightly end-onish in the RAO. And this is exactly what I did. This is exactly what I have done. I have tried to keep it little end-onish in RAO, and in the LAO, I tried to keep it slightly anterior. And I'm moving very slowly forward. We'll cross-check with contralateral injections. So that's a very slow movement, trying to, with the direction being controlled. So now again in RAO view, I'm almost in line. You see, it seems as if I am really in, which I was not earlier in the LAO view. And now I will cross-check in the LAO view. This actions actually can be best done in biplane. Now you see there it is. The LAO view also shows that the wire tip is inside the vessel. That's the still print showing. So I am in LAO, I am in RAO. That means I am intraluminal in both views once. That means I have crossed the lesion correctly. I am in the distal vessel intraluminal. And that is the 3D wiring concept shown. And now you just gradually rotate the wire and try to move forward. That's what's happening. So now you see in the LAO view there, because there are several parallel vessels. So one gets a feeling that maybe it isn't septal or something, but it's not, because the septals are in front, and there you see you cross-check in RAO, you are still in the vessel, and in LAO also you are in the vessel. So it is true lumen, and keep moving forward gradually and gradually, and then soon you will want to change this wire into a workhorse wire through the microcatheter itself. So there it is, the microcatheter comes down, and I have pulled out this Gaia, and now a workhorse wire, the Sion regular wire comes in. And beyond this, it becomes a regular case. So we can just see a couple of injections, some balloon dilatations. And then I think I did this with IVUS sizing. So we have a small size balloon, 1.515 or something. And then to look for patency being brought up. So that's the balloon. Well, it was a longish segment that was diseased, so multiple dilatations needed. So now you get patency, and then I think we can complete the case. Although we had parts of IVUS and things, but I think in the interest of time, I will just move to the final injections. So that's the vessel opened up. It was some diffuse disease distally, not uncommon with CTO vessels. So we got a good final result. So I think with this, the case is complete. What I have shown is the concept of 3D wiring and the success based on 3D wiring for antegrade wiring, which is largely done on a biplane concept. And you have to maneuver wires in both the directions. Thank you.